Welcome to the Royal College of Paediatrics podcast. This is the first of a short series on health inequalities. My name's Helen Stewart. I'm the college's Officer for Health Improvement. I am also a consultant in paediatric emergency medicine in Sheffield and a transport doctor in the Northwest. I'm joined today by two of the guys from Liverpool who are going to introduce themselves. Ian, do you want to start with you?
Oh, hi. So I'm Ian Sinha. I'm a consultant respiratory paediatrician at Alder Children's Hospital in Liverpool, and I work as an associate professor in the University of Liverpool, and I co-direct a research group within Alder called the Lab to Life Child Health Applied Data Centre.
And I'm Alice Lee. I'm a paediatric trainee in the Northwest, and I'm currently a clinical innovation and research fellow in the Lab to Life Centre, doing a PhD in respiratory health inequalities with Ian.
Thanks for joining us. We'd start by talking about what got you guys interested in health inequalities. What was it that brought it to your attention? Ian, I don't know if you want to start with that one.
Yeah, I mean, it's something that has always been visible to me as both as a medical student and as a doctor, even before being a medical student. When I was at medical school at Newcastle, I had a really inspirational mentor in many ways, who was a community paediatrician called Tony Waterstone, who was just a great guy. And he was the person really who gave me the confidence to start questioning why we're doing all the things that we're doing, only to just sort of send children into situations that make them sick. And when I started medical school in 1997, there was a shift in government from the Conservative government to the Labour government, and there was a real ambition to try and end child poverty. And so while I was at medical school, that kind of opening up children's centres and Shore Start centres. So it was just an interesting time to be around and thinking in that space. And I think that's really what sort of prompted my first interest in this. And obviously, as time's gone on, as a respiratory paediatrician, I think something like 70 to 80% of what I see is just simply the manifestations of poverty in one way or the other, or are complicated by poverty in one way or the other. So, it's just very ingrained in what we do.
Definitely. I work in an emergency department, and it's a huge part of a lot of our presentations. Alice, what about you? What got you interested?
Very similar things, really. So similarly throughout medical school and early in training, being very aware of, the injustice of what I was seeing, presenting to the hospital, and the situations that we were sending families and children back into. And then during my paediatric training, I think it sometimes is a bit corny, isn't it, to quote Michael Marmot, but the whole idea of why send someone home to the same environment that's making them sick. So I knew that was an area that I was interested in, and spent some time going, signing up to different programs to learn more about that. And eventually, fortunately, was put in touch with Ian by one of the respiratory consultants in Manchester.
Excellent. So obviously you're both interested, but why do you think paediatricians as a profession have a role in addressing child health inequalities?
If we think through health inequalities through the life course, and Alice mentioned Sir Michael Marmot and his team, who showed that there's an unprecedented worsening of life expectancy for particular groups, particularly the most deprived decile of people, and especially, and we saw this early in women. Actually, when you start to trace that back, when you trace back any of the health inequalities through the life course, that track begins in childhood. These children are on two separate tracks. You've got children who are disadvantaged and those who aren't, and it's not a case that these tracks diverge. They just start off in a different place. And so what we're really seeing in childhood as paediatricians, if I think back to my clinics, all I'm seeing when I do a clinic or do a ward round is I'm seeing a child in a snapshot of what their lifelong lung journey will be. Something's led up to that point, and something will happen from that point onwards. And when we see children in clinic, when I do my bronchopulmonary dysplasia clinic with babies who've gone home with neonatal lung disease, I'm not, part of what we do obviously is keeping children safe now. But I think as paediatricians, we are kind of bought into the idea that we should be thinking about the well-being of these children in 30 years' time, in 60 years' time, in 90 years' time. We want children to live their best life. That's why we go to work and do what we do. We want them to live their best life, to fulfill their potential, achieve everything they want to achieve. And that requires a lifelong approach. And we're in a unique position as paediatricians because our adult colleagues who we know and love are basically just managing the decline of lung health or gut health or brain health in adulthood. But really what they're doing is addressing things that went wrong 40 years earlier in that person. So we're in a unique and crucial position to try and advocate for a lifelong change where you get the biggest bang for your buck by investing in making improvements early.
At least when I was in medical school, it was always classed as the wider determinants of health. And I think that kind of puts it in a niche interest box rather than what it is, which is, as Ian said, the vast majority of the reason we're seeing children and adults coming to hospitals and coming to GP services. And so a phrase that we've co-opted from one of Ian's colleagues is that they are now the core determinants of health and the core determinants for child health. And that's how we should be seeing these things.
Oh, interesting. That's a really interesting approach because I think I read somewhere that the health service is only responsible for about 15% of health outcomes. And actually so much more is due to those environmental, social factors. I think from my perspective as well, just remembering that is a crucial contact with the family that actually we all have a responsibility to make use of to improve the child's health, because that might be the only contact they have for quite a long time, particularly in the emergency department, and primary care is so overwhelmed at the moment, isn't it? So how do you start to approach this with families? How do you start to have that conversation?
I learned a lot about this from Ian, so once again, I'm going to...
I mean, when we think about how we communicate with people in general, sometimes we get it right, sometimes we get it wrong. But the key thing is we've got to be honest with people, don't we? The golden rule is don't know anything that your patient doesn't know. And I firmly subscribe to that. There has to be a complete trust. And if there's something important that could be impacting on their child's health, people have a right to know. And as soon as we accept that, then things become a little bit easier to do. I'm sure some people, and we're often told that people feel uncomfortable about asking about living situations and about finances and about poverty and things like this. I guess the way that I look at it, these things, as Alice quite rightly says, are the core determinants of health. The analogy would be, if I had a cough and went to a GP and he didn't ask if I smoked, I'd feel a bit shortchanged. This is the same thing. If we know that there are things that can impact on someone's life, we should be asking about them. And conversely, I think we sometimes forget the impact of what we recommend, of what we say and do, to families, has its own burden for them. Every time we say, come back to clinic in 6 weeks, that's a big chunk of their time that they're not earning, that they're paying for parking, travel, childcare, all these kinds of things. So it's really important that there's an open discussion about both those aspects, how their living circumstances might impact on their child's health and how their child's health might impact on their living circumstances. So I'll be honest, I've never really had a problem myself. No one's ever questioned why I'm asking these things, I think. I think it's important that we ask it to everybody. I'm not a believer in the idea that we should target groups that we think might be poor and talk to them about it. Ask everybody. We don't know who's struggling just because of how someone's turned out. We've got some, certainly in my life, I've seen really rich people who look like they're wearing clothes straight out of the bin, and I've seen really poor people who pay so much sort of respect to the NHS, and the people, the way they want to show that is by turning up immaculately. And so it's impossible to tell from what people look like. I know of families where there is a really high level of income, who's someone in the family has got a gambling problem and the money just goes. So there might be a huge income and zero wealth. So we can't pick that.
No, I completely agree with everything Ian was saying there. And I think, especially for people who are feeling a little bit nervous about speaking about these things with families, for me personally, learning more about what we can do for families, learning more about the community organisations has given me a lot more confidence in approaching these topics, because I think sometimes as doctors or medics, we're problem solvers. We like to fix things. So I do worry that sometimes we don't ask these questions because we don't have a fix for them. So it has helped my confidence from working with people in the community, that I know if someone says, actually, yeah, I'm really struggling in this area, I know where to direct them. And I can say, oh, my colleague from Citizens Advice, or I know someone in shelter who would really be able to help with that. So that I would recommend people familiarising themselves with what support is in their local area.
That's great advice. I think that probably applies to quite a few things, isn't it? People want to know that if you're opening up that difficult conversation, that actually there's a purpose and you can actually help in some way. So do you have a kind of an opening gambit, a question that you kind of start that conversation with?
Can I say what Ian it's a really nice way that you approach things in the BPD clinic, actually, that I've picked up. And especially for new patients who are arriving at the BPD clinic, I think we're privileged in that situation where it's automatic to say, how long were you in the neonatal unit? Were you working before you had your baby, and do you have maternity cover? And asking that kind of thing to see how long they've got off after their discharge from the neonatal unit.
Right.
And I've seen you do that a few times, and that seems, because it makes it a universal issue of having a new baby and the experience of being in neonates, and then filtering it down to actually that can be really costly for families, and how are you coping with that?
Interesting. And what about when you're in respiratory clinic, with the older families where you've not necessarily got that hook in with the maternity leave?
So the hook in the asthma clinic is a different one. It's more a biological hook. So the hook in the asthma clinic is asthma is a disease of airway inflammation. There are various things that can drive airway inflammation, and actually quite a lot of those things are related to poverty. And for the last 30 years, we've got hung up on, rightly, we've focused on parental smoking, and that's a really important thing. There's a whole load of other stuff. Poor quality food can drive airway inflammation. So that gives us a route to say nutrition might be leading to the pheno being up. And, something like 60% of our severe asthma clinic is overweight or obese. So that gives us a route to say, well, I wonder if we think about nutrition as being something that might contribute to your asthma. We wonder if, that sort of ultra-processed food is important. And Alice took the lead at our end really on developing some work for the RCPCH toolkit. And one of the things she came up with was this a cost clock capacity analysis. In other words, simple things that we say, or we think are simple, we say to families, well, just eat better. Go on, go and eat better. Actually, when you sort of break down that process, there are so many different steps and there are so many different barriers that gives you a route in to say, well, I wonder why nutrition is a problem. And do you know what? All roads lead to poverty. It does for that. Similarly for housing, we say to people, well, if your exhaled nitric oxide, a good marker of airway inflammation, if that's persistently high, we know you're taking your treatment, we know you're not smoking, we know this, and this. I wonder if there's something in the home that might be triggering that, So there's a biological and clinical route in there. When we see children on intensive care, the route into talking about stuff. And someone bumped into me yesterday, we were reflecting on a case that we had of a child who literally went on ECMO because of a sort of respiratory infection. And when we traced it back, the house was absolutely sort of completely uninhabitable almost because of the mold. And our route into that is to say, all children get chest infections. Hardly any of them go on ECMO. are there other things? And, parents don't feel judged at that point because they're part of the circle of that team. They're a central part of that team. It's not us and them, it's not us asking them. I'm sure when we get it wrong, it's perceived by parents as us asking them, so we have to do it sensitively. But this is very much about putting together as much information as we can to help that child, and we're all there for the same reason. So the hook is, whatever it is that you're seeing that child for, there is a 95%, unless you're seeing them for gout, there's a 99% certainty that there is some evidence that that disease could be, contributed to or is associated with or increased risk or different type of phenotype, whatever it is, with not having so much money. And there's 100% certainty that whatever it is that you do will have an impact on that family's finances. So yeah, there are always ways in, and doing it early and doing it sensitively is important.
So basically finding a medical element of that child's care and exploring it that way rather than just coming out and asking.
Absolutely.
Yeah.
I think, the work so the parent champions that myself and Ian work with as well, they have been really instrumental in helping me approach these topics as well in the hospital. And so much of it is avoiding that stigma and being really careful that you're not perceived as being voyeuristic or trying to put them in the place. And that links into what Ian was saying, is that actually if you're sharing knowledge with them so that you are on the same page, that does help to address that stigma and make it so that actually, here is what I know. You need, you tell me what you know, and let's work on this together.
Yeah, I mean, that's definitely been our challenge in ED, in that we've created this leaflet for resources, but how do we make sure the right people get them? Because as you say, we can't profile people and say, oh, you look poor, here's this leaflet, but also people who don't need it, don't want it, and we're giving it to everybody, but it ends up on the floor. So that's been a real challenge to work out how to make sure people who need it do get that information.
And what's your approach been there, Helen?
Well, what we've done is we've created a welcome to the emergency department leaflet. So that kind of kills two birds with one stone, in that it explains the process, explains what might happen, it explains why there might be a wait, where the toilets are, where the water fountain is, but then also the link is on there so that actually if we point people in direction of that, then they get the information as well. So it's still in a PDSA cycle. We're still working on it, but
there was some work that I spoke with an anaesthetic trainee from your neck of the woods, Helen, who was again interested in going back to what you said earlier, probably a similar thing to ED. She said, we want to know as anaesthetists what can we do about this? And we were just shooting the breeze and talking. And actually one of the key things that came out was that in the same way that you said, we might be the only person, the only professional that has touches base with a particular family. We kind of realised that an anaesthetist taking someone for an appendectomy or whatever they're taking for might literally be the only person that looks in that child's mouth for their entire life. So it's about just taking all those opportunities. It'd be really interesting to see what comes out of that work in ED in Sheffield as well. I think there's a lot to learn from there. And Alice, with the parent champion model that she said, these are women that have got both credibility and reach that we don't have. These are people that we got a grant to work in children's centres in Liverpool, talking to other mums, new and expectant mums, about smoking, housing, breastfeeding, poverty, bronchiolitis, people's rights, all these kinds of things that impact on child health and childhood respiratory health. They've been really useful because they've fed back to Alice some of the terminology that we kind of take for granted as being acceptable. So you had some good examples of them.
Oh yeah, so recently the parent champions themselves can also directly refer families to the perinatal citizens advice scheme.
Oh, brilliant.
And what the feedback that we got was that families don't like the word refer, because as soon as they say, I can refer you to someone, they were saying that a lot of families are like, no, I don't need any referral. And it's the fear of, I'm going to be criticised for this situation that I'm in.
That's very interesting.
Yeah.
We got similar feedback about the word vulnerable, actually, from some of our parent groups. They don't like being referred to as vulnerable. And that's the young people as well, particularly. They feel that kind of is a stigma. And actually, as someone pointed out, we are all, at some point in our lives, could be considered vulnerable. There's always a period in our lives where our mental health might not be great, or we've got an illness, or we've lost a job, or there's always, everyone has the potential to be vulnerable at some point in time, and they don't like that phrase. So it is really important to get that information from families, isn't it?
Vulnerable is a great example. It's something that we think, and by great example, what I mean is a great example of why all these things, however little, however big, have to be co-developed with families and with communities. The families with the least, in some ways, they're the least vulnerable, because they are so strong, they're so resilient, so resourceful, so intelligent, so good at getting through with, a billion walls in front of them, we're surrounded by barriers, and so I think vulnerable is a great example of a word that we use as a throwaway word, which is incredibly unwitting.
It's so weighted, isn't it, that word?
Yeah. So have you ever had a negative reaction to bringing up any of these conversations?
I've personally not had a negative reaction. I think quite a few of us have experienced, and including the parent champions have experienced, what Ian was saying is that actually, because there is so much stigma related to deprivation and poverty, that you may not get, the way that you approach it, you may not get the response. You may not get the person to say, actually, I'm really struggling and I do need this help. And that is more challenging in terms of building up a rapport. And I guess we're more privileged because we're seeing children again and again in clinic to get that insight.
What about you, Ian? Have you ever had a negative reaction?
In context of what Alice has just said, which is very important, which is that they've come to, by the time people get to tertiary services, they often treat us a little differently. They speak to us a bit different, and I totally get that. And it's wrong, and I do feel sad about it, but it does make my life a bit easier. And so it all comes back to the stuff we were taught in first year medical school. How do you speak to people? What are their ideas, concerns, expectations? How do you communicate? What do you look like when you communicate? How do you sound? It never comes down to this was seen as a very sensitive topic.
I guess that goes back to what we were saying about the paternalistic aspect of medicine as well. And a lot of the families that we've worked with have said, if I'm in the hospital with my child and I'm worried, I don't want a telling off, and I don't want a telling off behind a curtain where I know the whole of the rest of the ward can hear me.
Ah, yes, of course.
Which just even increases the stigma even more. So I think choosing both the approach and the setting, and making sure it's not paternalistic.
Definitely. Lovely. Well, thank you so much for taking the time to have this chat today, guys. Really appreciate it. It's been so interesting, and hopefully it'll give everyone something to think about. If anyone out there is interested in learning more, Ian and Alice have both worked really hard on our toolkit, which is available on the website. There's some stuff in there about having difficult conversations, as well as some other information which will be covering in future podcasts. It's at www.rcpch.ac.uk/shift the dial, or at rcpch/health inequalities. Yeah, thank you so much, and it's been a real pleasure.
Thank you very much.
Thanks for taking the time with us.